So today I am very excited to have Dr. David Bates with me. Dr. Bates is the Chief of General Medicine at Brigham and Women's Hospital, where he's also the Chief Quality Officer. But the real reason we have him, beyond those very important positions he has, is that he has been the sort of pioneer in studying patient safety, health information technology, and how they intersect. Dave, thank you so much for coming.
Thanks for having me.
So I want to start off by first taking a theoretical example. Here we are at the Harvard School of Public Health. We're right across the street from Brigham and Women's Hospital. Imagine the Brigham is a typical American hospital. And I am a patient, I have some illness, and I go to the hospital. I go to the Brigham. What am I at risk at? From an adverse event, patient safety point of view, what are bad things that could happen to me if I'm at the hospital?
Well, of course, we try to do as much as we can to keep you from getting any of those bad things. But the fact is that there are a number of things that can happen. You could have an adverse drug event or be harmed by a medication.
So I'm going to just take a minute and write these down. So adverse drug event, keep going.
Yep, you could have a hospital-acquired infection.
Okay. So I'm going to call that HAI, hospital-acquired infection.
Yep, you could fall. You could develop a pressure ulcer.
Okay.
You could have a surgical complication.
Okay.
And you could have a deep venous thrombosis. Those are really the main causes of harm.
Okay, I'm going to call that DVT, deep venous thrombosis. So let's go through each of these a little bit more carefully. Adverse drug event, how do you think about it? What is an adverse drug event?
An adverse drug event is any injury that's caused by a medication.
Okay. And about how often do these occur in a typical, let's say, American or sort of Western hospital?
They happen in between 7 and 15 per 100 admissions. Okay. So infections, it's about 3 per 100 admissions.
Okay.
Fall is about 1%.
Okay.
Pressure ulcer is about 3%. Surgical complication is about 2%. You have to have surgery, obviously, to have a complication. And deep venous thrombosis is about 1%.
Okay. So none of these numbers offhand look very big, but is this a big problem?
It is a big problem. When you add them up, it turns out that somewhere between 10 and 25% of patients who come to the hospital have something bad happen to them as the result of the hospitalization. What the exact number is depends a little bit on how hard you look.
Is this a uniquely American problem, David?
No, we now have studies from all over the world that show that the rate of harm is on the order of this magnitude. In most of the international studies which have come from developed countries, the rate has been about 10 in 100 admissions.
Do you have an approximate sense of how many of these are preventable? For instance, let's talk about adverse drug events. Just offhand, what proportion of those might be preventable?
It varies a great deal by category, but for adverse drug events, 70% roughly are preventable.
Wow. So 70% of these could be prevented based on what we know today.
Yeah.
How about infections?
For infections, we used to think that the proportion was really low. Now we think that it's possible that nearly all of them could be prevented. Wow. So it's probably on the order of 80%, for example.
So you think that if a hospital or an organization really made this a top priority, a large majority of these things could be eliminated?
Yes, absolutely. And many hospitals have already done that for some of the most serious infections.
Okay. And just for a minute, if you don't mind, can we break these down into types of infections?
Sure.
Because obviously patients can suffer a variety of different infections. How do you think about them? What are the major types?
The catheter-related bloodstream infections are a really important one. So those happen to people when they have most often a central line placed, and they get a bacteria in their bloodstream as the result of having that central line there.
Right. So these are sort of big catheters that we put into people's necks or groins for giving them medications, other things.
Exactly. Another important one is urinary tract infections, especially catheter-related urinary tract infections.
Okay.
So that occurs after someone has a Foley catheter placed. It turns out that Foley catheters are valuable in certain instances, but they're probably placed more often than they need to be, and they're often left in too long. Surgical site infections, pretty straightforward. This is where you have an open incision, getting an infection in that site.
And some of them are presumably deep infections, some of them are more superficial ones.
Correct. Fortunately, most of them are superficial, but the deep ones are much more serious. And then Clostridium difficile infections are another. So that's an infection that occurs in the gut. It
Yep.
occurs most often when you've been exposed to an antibiotic. There are certain antibiotics that cause it much more often than others.
Okay.
And it can cause very serious diarrhea, and people can get very, very ill from
Do
it.
people die from it?
Yeah, absolutely.
Okay. So this is often antibiotic induced, though it sounds like I think I've heard some chemotherapy drugs, other things can cause it as well.
That's correct. Sometimes it happens just from person-to-person transmission, too.
And then sort of other nosocomial pneumonias is something else?
Yes, so ventilator-associated pneumonia is another one.
Okay. So what we're going to talk about is VAP.
That's the biggest category. And if you have an endotracheal tube put in place, that just really substantially increases your likelihood of getting pneumonia.
And your contention, really based on a variety of evidence, is that a large majority of these are preventable.
Exactly. You know, and the knowledge that that's the case has really come about in recent years. And
Yeah.
when I was in training, we were taught that many of these things are complications. They just happen to people.
Yep.
And there wasn't a lot that we could do to prevent them. We've learned that that's not true.
Just from a broad strategy point of view, what are the kinds of things that are helpful?
Overall, what's been most useful is to identify a bundle or a set of things
Yep.
that if you do all of those, it really very dramatically decreases the chance that someone will suffer that infection.
Okay. Hand washing? I heard a lot about that.
Hand washing is also a very important approach for preventing infections, and that is really a cornerstone which underlies hospital-acquired infection prevention in general.
Got it. So that would be helpful across all of these things.
Yes, absolutely.
Terrific. So falls. Are these all serious?
Most of the time, patients don't suffer a serious injury, but a small proportion of the time they do suffer an injury, either breaking something or having bleeding as a result. Sometimes people get what's called a subdural hematoma.
Wow. So they hit their head.
Hit their head and then have bleeding inside their head.
So those are obviously the most serious complications.
Yes. Yeah.
And if you're thinking about preventing these things, what's a general strategy you can use?
Well, the first thing that we do is to try and profile people according to their risk of fall. And some people are at much higher risk than others. If somebody is at high risk, we then put in place what are called fall precautions, which is a whole set of things that we do to try and decrease the likelihood, first of all, that they will fall, and the second, that if they do fall, that they actually hurt themselves.
Got it. What are some clinical features of the kinds of things that put people at risk for falls?
The biggest thing is anything that makes you confused. So if you are getting drugs that make you confused, or if you're demented, it also increases your risk of fall if you're incontinent. That's another big factor.
Got it. I'm going to move on to talking about pressure ulcers. Can you describe a little bit more clinically just what this is, what happens, who's at risk? How can you do anything about it?
Another name for a pressure ulcer is a bed sore. It's a sore that you get basically from lying in one place for too long.
Yep.
And pressure ulcers can have very serious consequences. So they can be associated with infections. They do dramatically prolong length of stay. They tend to cost a lot.
These are things that develop when people essentially are immobile. They're just not moving very much.
Yeah.
And they can sometimes be superficial, but sometimes they can really become quite problematic.
Exactly.
And can you do anything to prevent these things?
There's lots that can be done, and I think that there'll be much more that it will be possible to do in the not-too-distant future. So there are a variety of technologies that are becoming increasingly available that can track, for example, whether or not somebody's moving.
Got it. And if you're in a place where you don't have a whole lot of technology, for
Yeah.
instance, what can you do that's maybe more manual, less technology-driven?
Sure. So there are good approaches for this. There are also risk approaches for predicting who will get a pressure ulcer, and then it helps a lot to make sure that you turn a patient who you know is not moving very much on a regular basis.
Got it. So one thing that I'm hearing on a couple of these different things is part of the strategy for improvement is not necessarily to just try your prevention effort on everybody, but maybe to try to identify some high-risk people and put extra effort on those. Maybe you can do something for everyone, but extra effort on high-risk patients.
Exactly. That's a big part of the prevention approach.
Okay, great. Surgical complications, what kinds of complications are we talking about?
There's a whole array here, but it ranges from doing things in which you nick an organ while you're doing an operation to cutting something that you did not intend to cut.
Yep. So wrong site surgeries?
Yes, exactly.
And presumably those happen pretty infrequently.
They're very infrequent, fortunately.
Yeah,
But they can be very bad when they do occur.
I can imagine. Let's talk about deep venous thrombosis. other complications. What is this clinically? What happens?
Yeah, so this is developing a blood clot, and they typically occur in the veins, usually in the legs. And the dangerous thing about them is that the clots can then sometimes move up to the lungs and cause pulmonary emboli and trouble breathing and even death.
So you said about 1%, Dave?
Actually, I think it's more like 3%.
Okay, that number should be about 3%. So 3% of patients end up developing a deep venous thrombosis.
Exactly.
And some chunk of those people will end up developing a pulmonary embolism if you
Correct.
don't catch it.
Correct.
And treat it. Okay. Who develops DVTs?
So it's largely people who are at bed rest, and increasingly the people that we bring into the hospital are quite sick, and they do end up spending most of their time in the bed.
Got it. And so the risk is basically from immobility as one of the main risk factors.
Exactly.
And can these things be identified or prevented?
They absolutely can be prevented, and we now have prevention regimens, a variety of different approaches. Those are both medications and then they're mechanical devices.
Got it. So mechanical devices basically that keep the blood flow?
Exactly, that squeeze the leg on a periodic basis. Sometimes people don't like to wear them. They say, oh, it's keeping me up at night.
Yep.
But if they know what getting a blood clot is like,
the trade-off may be worth it.
Exactly.
Yeah. And then medications, presumably you're talking about anticoagulants, things that sort of help prevent clots.
Correct.
Okay. So this is very helpful. This is what it might look like in a typical American hospital. We talked about how these numbers might look very similar if you're in a hospital in England or Australia or Canada. What if you're in a hospital in India or China? And I don't mean to pick on those two countries specifically, but once you get out of the high-income countries to low and middle-income countries, does the pattern look the same, or are there broad differences?
Well, I would say there are a couple of places in which there are substantial differences. Notably, the risk of adverse drug events is a bit lower.
It's lower.
Yeah, and that's in large part because fewer medications are used in developing and transitional countries.
Got it.
Because many of the most dangerous medications are actually quite expensive. And then infections are more common.
So if you think about it from an overall profile of patient safety, it sounds like what you're saying is your risk of having an adverse event, having something bad happen in the hospital, probably no different in a lower middle income country, but maybe a little less likely to have a medication problem, adverse drug event, but maybe a little more likely to have an infection.
Exactly. And the risk of most complications is probably somewhat higher. The chance that it could be prevented is also a bit higher.
Got it.
The other broad category that we don't have on this list is birth-related injuries, and those are extremely important, especially in developing countries. You know, one of the things that happens in developing countries is that birth rates are very high, so it's something that happens a lot, and yet the resources that we have to deal with things are somewhat more limited. And both fetal and maternal mortality rates and injury rates are substantially higher in developing countries.
Got it. So this is not just about the fact that when women come into the hospital or a birthing center that they might have the normal complications of childbirth, but you're saying that in the process of care delivery, there may be new things introduced that can cause problems.
Yeah, that's part of it. I mean, part of it too is that women often come later to birthing centers. So they come, after they're suffering a complication.
I'm going to take a step back and say, here we are. We've identified a set of adverse events, injuries that happen due to medical care. We've talked about it for high-income countries. We've talked about it for low- and middle-income countries. Let's just say we put all this together. From a population health point of view, is this a small deal? Is this a big deal?
If you put it all together, it's actually a really big deal. If you look at causes of death, it's a little uncertain what the exact numbers are, but in developed countries, this probably comes in right after cardiac issues and cancer. It's probably the third leading cause of death. So it's really a serious issue.
And there's some work that we've done together, supported by the WHO, that tried to quantify disability-adjusted life years lost, sort of how many years of life are lost. We found that about, 23 million disability-adjusted life years are lost around the globe from just these kinds of events.
Exactly, and there were other things that we couldn't include, and we made very conservative estimates, I would say, throughout as to how big the magnitude of harm was.
Let's take a minute and just kind of identify what were things that you think are clinically important that we weren't able to get to.
Right, so among those were counterfeit drugs, unsafe injections.
Unsafe injections, yep.
And the other big one we already mentioned, which is the birth-related injuries.
Yep. So this is very helpful, and the main reason we couldn't get at this is really data issues. Is that fair?
Exactly. So, for example,
Yeah.
for counterfeit drugs, some estimates are that up to half of all the medications in developing countries are not truly what they're supposed to be. Now,
Wow.
the exact proportion is uncertain. The benefit that people would have gotten if they were the real thing is also not clear.
Yep.
But it's pretty clear that it's a big issue.
When we talked about adverse drug events, we were talking about giving legitimate drugs but having problems from that. Here, the issue is even if you give the right treatment, there may be, in some instances, as much as half of the medications may not have the exact substance and dose that it's claimed to have.
Exactly. And then around unsafe injections, for example, in some
Yep.
parts of the world, it's routine to give a lot of injections. That's been a long-standing practice, for example, in India.
Yep.
And it was quite common to reuse needles, which obviously carries with it the risk of HIV transmission as well as hepatitis B and C.
What I'd like to do now is move from inpatient care, which is where we have been, to talking about ambulatory care.
Sure.
This is obviously where most people get most of their health care. Patient safety issue is still an issue?
Absolutely. A big issue. We don't have as much evidence as we do for the inpatient setting, but it's still a very important problem.
Okay, so if we're talking about ambulatory safety now,
Yeah.
safety for patients kind of in the outpatient setting, what are the big issues?
There are adverse drug events again.
Okay, so the same one pops up here again.
Yep. One thing that's really important is that if you call patients and if you ask them if they've had a problem with one of their medications, you find 7 times as many as if you just look at the record itself.
Wow, 7 times as many.
Exactly. So problems with medications are very common in the outpatient setting. Diagnosis-related errors. We probably know less about these than about any other category, but if you look to see what people get sued about in the ambulatory setting, this is the top category. So someone comes into your office with chest pain,
Yep.
and you think it's nothing, that it's reflux, and they end up going home and having a heart attack. A laboratory follow-up is an issue. The biggest issue is with labs that suggest that a cancer might be present, and the issues tend to be lung cancer, breast cancer, prostate cancer, colon cancer.
Okay.
So someone comes in and they have a small nodule on their chest X-ray, and follow-up is recommended, but you forget that they had that, and it turns out that it's a lung cancer.
So the follow-up issue here is someone gets a diagnostic test, maybe a biopsy, breast biopsy, colon biopsy, and the patient doesn't follow up, and the system doesn't reach out and tell them that this is a problem.
Exactly, and it's an issue even before the biopsy. I mean, once you get to the biopsy, we actually do all right.
Yeah.
It's more that there's something that suggests that the patient should have had a biopsy.
Got it. So
So a woman comes in, they have a breast lump. Let's say they have a mammogram, and that appears okay. Well, it turns out you shouldn't be reassured by a mammogram alone. You need either an ultrasound or a biopsy to be sure that it's not something serious. Interestingly, surgical issues, especially because so much surgery is being done in the ambulatory setting now. There are many of the same kinds of issues. We're now seeing people do procedures like transurethral resection of the prostate, or TURP, which is a prostate operation in the outpatient setting on a routine basis. Another example is laparoscopic cholecystectomy is sometimes done as an outpatient.
Yep.
Those kinds of things can result in complications with a finite rate. And if the patient doesn't come back and get the complication dealt with, it can be a serious issue. Another one would be issues with referrals.
Referrals.
So the big issue here is you come in, you have a problem, you tell your doctor, and they tell you to go someplace, and you just don't do it.
Okay.
And right now, we don't have a good way of checking to see whether or not you did. Now, most of the time, that's not a big issue. But let's say you have a skin lesion that looks like it might really be a cancer, and you don't go and follow up. That's a big safety issue.
Got it. I'm going to push back for a second and say, but wait a second. You told the patient what to do, and the patient didn't do it. Why is that a systems problem? Why isn't that just a patient problem?
Well, we should really be closing the loops in our system. And the fact is that we don't. Our legal system certainly considers it the doctor's responsibility as soon as a problem like this is identified.
Got it.
And the onus does, like it or not, fall on the provider to get the patient to go get whatever it is checked out.
The point you're making is that from a systems perspective, that patient, even if the patient chose not to follow up, it's really the system's responsibility to make sure something happens.
Exactly.
Okay, so here we are. We have 5 as sort of common, important issues. If I'm, instead of in the U.S., I am in Canada,
Yeah.
or I'm in England, do you think that this list looks about the same?
The issues do appear to be about the same. And if you look at the overall magnitude and add everything up,
Yeah.
the magnitude of harm is probably roughly the same as that occurs in the inpatient setting.
Wow.
Although we don't have good studies to back that up.
Got it. So that is really interesting because, right, most of our work has been on the inpatient side. You're saying if you put all this information together, the harm may be almost as big on the outpatient side as inpatient. And then if I'm hearing you correctly, even though we don't have terrific data, once again, not just a US problem, in other high-income countries, the list looks similar. One of the things we talked about on the inpatient side was that medication issues were a little less common for low-income countries, but infection rates were more of a problem. Do we even have the data on ambulatory safety in low and middle-income countries to make any broad generalizations? What's your best guess?
We don't have much data from developing countries. We do know that medication-related problems are less frequent,
Yeah.
in part just because they aren't using as many medications.
Let's talk about those two terms, medication errors, adverse drug events. Hear people use them. Are they the same thing? Can you help define what those are?
So they're not the same thing. Medication errors are any error in the process of giving a medication. Adverse drug events is an injury or harm to the patient that's caused by a medication. So some adverse drug events are associated with a medication error. Those are the preventable adverse drug events. But most, depending on the setting, are not. And some medication errors have much more potential for harm than others. There are many more medication errors than there are adverse drug events. And if I were drawing another circle, these are what we call potential adverse drug events, which are errors that have the potential for harm but don't actually cause harm. So that's a third group.
What proportion of adverse drug events are due to medication errors or are, let's say, preventable?
In one big study that we did, the figure was 28%.
Okay.
Now, since then, we've learned a lot of things that we didn't know at the time, and we think the proportion is much higher. In some other studies that we've done recently, the figure was as high as 70%.
So let's stick with the hospital setting.
Yeah.
And let's say I am a patient and I go to the hospital, I have pneumonia. Walk me through the process of your ordering the antibiotic to my getting the antibiotic. What are the kind of key steps and where can things go wrong?
Sure. So it's a complicated process. The first stage is ordering.
Okay.
Then the order goes to the pharmacy where it's dispensed. The order then comes back to the unit where the nurse administers it. And then the patient actually gets the medication.
So the patient receives.
Yes, exactly.
And obviously, this is a little simplified because I can imagine there's lots of steps along the way.
Right. One step that I left out is the step of transcription, which used to take place between ordering and the pharmacy, because at least in older processes, the pharmacist always had to transcribe the order.
Got it. So in this case, you're the physician, you write down penicillin.
Right.
And then that has to get transcribed into the pharmacy system by the pharmacist.
Right. If you look at what proportion of the errors, roughly half are actually at the ordering stage. Pharmacy errors account for about 10% of errors, and errors at the administration stage are 30%. And in the old days, 10% occurred at the transcribing stage. And we typically, in the inpatient setting, have not monitored the errors that relate to following the patient up after they get them. But that's
interesting.
That's important too.
So that's interesting. Half of it is happening with you.
No, exactly.
And then another half is happening as that order leaves your hands and kind of makes its way through the system.
Right.
Tell me what we know about what to do about these things. Do we tackle them at each individual stage? What are the kinds of things that work?
The single most powerful intervention for reducing medication error frequency and reducing the number of preventable adverse drug events is computerizing prescribing, or putting in place computerized order entry.
Okay.
So you computerize the ordering. The doctor writes the order on the computer. We make sure we can read your handwriting, which most of the time we couldn't before using the computer. We check it to make sure that the patient's not allergic to the drug, that there are no other drugs that shouldn't be given together with that medication. And and check it for a number of other things. Adjust it for your level of kidney function, for how old you are. After all those checks, the order is written. It then it can go electronically directly to the pharmacy.
Great.
So the transcribing errors, when you do this, go away altogether because you basically don't have to transcribe it anymore.
And when we're talking about this, it reminds me we could have spent a minute talking about the kinds of errors here. You're saying maybe I got the wrong dose, maybe I'm giving a drug which the patient is allergic to, maybe I'm ordering penicillin, but it interacts with another medication they're on. That's the clinical decision support that's picking up all of those and alerting physicians.
Exactly. And even if you don't have a lot of decision support in place, if I just suggest to you the right default dosage for medications, that by itself, which is a very simple thing,
Yes.
is pretty helpful at reducing the error rate.
I'm going to ask you to tell a story because when I was a medical student years ago, you did this great study that I loved with ceftriaxone dosing, 2 grams to 1 gram. Do you mind telling me that story?
No, it was a very ironic thing. When we turned order entry on, we set the default dosing frequency for ceftriaxone at BID or twice daily.
Yeah.
And the main advantage of the drug is it can be given once daily.
Yeah.
We didn't even know exactly why we did that. It just somehow happened.
Yeah.
And what happened as a result was overnight, 90% of the time after we put in place order entry, the doctors were giving it twice a day. That was wasting a lot of money.
Yeah.
We just took the position of the cursor and moved it from BID to QD, or once daily.
Yeah.
That single change saved the hospital $300,000 in the first year.
Wow. And basically the physicians just switched their prescribing overnight.
They switched just overnight. We went from 90% one way to 80% the other, and we didn't have to go out and beat anybody up. It was really remarkable.
And what that tells me, and tell me if you interpret it the same way, is that physicians are assuming that the person who has set the default has thought about it and that's probably the right way to do it. Is that how you interpret that?
That's exactly right. And the corollary of that is that it's really, really important to get those things right, because if you don't, people will reliably make mistakes.
Got it. So you can actually, just as you had this amazing ability to fix something overnight, you can actually create problems overnight if you get the default dosing wrong.
Absolutely.
How much of that ordering stuff can we eliminate, reduce by this set of activities?
Well, so even a very simple ordering system reduced the serious error rate by 55%.
That's a big effect, just even the simple system.
Exactly.
What about this stuff?
So,
how do we begin to deal with those?
So there are a couple of strategies. One, and the one that's been the most powerful, is barcoding.
Okay.
So if you take medications and you barcode them in the pharmacy, first of all, you can check to make sure that you're dispensing what you thought you were. And we've showed that when we did that in the pharmacy, the error rate went down really substantially by roughly 30%.
So you can reduce these guys.
Yeah, it didn't go down. They didn't go away completely, because for some things it's hard to dispense using a barcode. And then we also showed that when drugs are administered at the point of care, that also decreases the error rate by around half. Now, some drugs are not given in pill form, right? They're given by vein. And there, the key technology is smart pumps, which are pumps that can be told what medication is being administered. You can have a library of drugs that's specific to the given location, so it's different for a cancer ward than for another unit. And that pump checks to make sure that the patient is getting the right thing, and if the nurse tries to administer too high a dose, they get a warning.
This set of technologies, I brought out BCMA barcoded medication administration. Sounds like it can make a pretty substantial dent in the medication errors.
Absolutely.
Okay. Imagine you're running a public hospital in India, and you may not be able to make big investments in electronic systems. What are kinds of things you can do to begin to chip away at this relatively big problem of medication errors and adverse drug events?
Yeah, so there are a number of things that any organization can do. One is just to make referential materials available via the web. That's possible in almost any setting.
Yep.
It turns out that there are certain medications which are quite concentrated. If you take those out of the clinical setting, that can be helpful.
Okay.
I think before too long, though, even in places like India, we'll be seeing relatively low-cost computer order entry applications being used for lots of ordering of medications.
Great. So three things that I heard, and let me just go through them a little bit. One is a lot of times just having access to reference materials about doses and interactions, especially for the common stuff, it's often not available. If you can make that available on a web page for your hospital website, that can be helpful.
Second thing was concentrated drugs.
Right. Concentrated drugs, the stories I've heard about this, especially around things like potassium, certain drugs that when they're available, people by mistake administer them.
Exactly.
And can cause fatal problems,
right,
especially with potassium. And then the third thing, thinking about electronic systems, I can envision, okay, so maybe sort of computerized provide order entry where you're sitting in a kind of a computer box, maybe expensive, but you can imagine mobile technologies where doctors can still get a lot of the benefits. And mobile technology is obviously widely available throughout the world.
Exactly.
Okay. So you think that is already starting to come, and we're only going to see a lot more of that?
I do.
Okay. And if you're running a public hospital in India and your budget is tight, would you say that's an area that you would focus on if your goal is to improve safety?
I think the first things I would focus on would be, for example, having a really good hand washing program. Doing some things like that. I mean,
Yeah.
I would do some sort of evaluation to try and sort out where my big issues were.
Yeah.
Before figuring out which place to put my chips on.
And let's say you find that medication errors and medication-related issues are a major problem. Sounds like electronic prescribing, even relatively inexpensive forms of that, can begin to make that.
Can have a big impact, absolutely.
Terrific. Well, thank you very much.
No, you're welcome.